This is a 73-year-old gentleman with bad neuropathy. He's been dealing with a non-healing ulcer over the left fifth plantar region, and he had some debridement done, wound care, did not heal. Pretty painful to get ABIs, and we couldn't get TBIs because his toes was very tender. So we got some arterial duplex, and we decided we'll take him to the angiogram. And the art duplex essentially said that the left PT was occluded with no distal reconstitution, no definitive flow in the lateral plantar, and AT had some moderate disease. So here's the iliac and the femorals, nothing too significant. So this is the angiograms below the knee. Again, rule number one when you're doing this, get good pictures, make sure your patient is kind of stable and not moving around, use anesthesia if required. So what we found was pretty nasty TPT disease and an occluded PT with no definitive distal reconstitution. Now, different ways to approach it. What I decided was use the theory of direct revascularization, open up the artery to where the ulcer is, and I decided to go after the PT. I said, let me open up the PT and the TPT and we should be good. So this is accessing the occluded posterior tibia. There you can see the calcified vessel down there, and here's it in a longitudinal view. So I was able to get in retrograde, and then I used the Mongo wire, which is a 018 Asahi wire, and I was able to get a loop, and then after that, based on how the loop behaves, and also one of the doctors by the name Dr. Tumuller describes something called where he curls the wire and then kind of almost performs a helicopter technique. So we perform that, then we get stuck halfway, then we stop. Now, as you heard from the previous talk, start with the 014, that's what I did, but eventually I upgraded to a 4.5 slender, and then I used a 018 glide advantage wire. So eventually I was able to cross through the CTO, I confirmed it. And then this is another story as to what happened. The sheath came out, and we anyway snared it, got the sheath across. I performed a phoenix atherectomy across it and took another angiogram, wasn't looking any good, and right here you can see there's no good flow. And remember, I cannulated an occluded posterior tibial artery, so clearly I needed to recanalize and get all the way into the lateral plantar, and that's what I did. I used a 018 system because I wasn't getting anywhere with the 014 system. So finally I was able to wire all the way into the lateral plantar, and at this point went ahead and did some ballooning, and after I did some ballooning, I was able to restore flow down to the lateral plantar. And then I had this little tear, which I was not happy, and obviously right down here to the TPT and peroneal looks like an absolute mess. So I ended up putting a tack stent, and as I did into the TPT, you see what I did to the posterior tibial? I shut that off. So I ended up double wiring it, and eventually I ended up putting coronary stents and managed to restore flow. I could have gone down below and did some more work on the lateral plantar, but I was 90 minutes into my case, and everybody gets tired. I said I'll follow him and see how he does, and so far he's done so good. But there's been a lot of issues with these cases. Again, as I said, it's a little controversial, and there's a lot of things I could have done better. Strongly consider antegrade if you are experienced and you have a good real estate. Definitely, the stuff I used in this patient added a lot of expense to it. Maybe staged procedures is good. Do the TPT peroneal, bring it back for the posterior tibial. We don't have enough tools to say, hey, this much of revascularization is enough. What is enough? There are different tools, but again, we don't have really good atherectomy devices for below the knee.